My name is Anna Dominczak, and on behalf of my co-chair, who is not Professor Ryan Towers, but Professor Gary Jennings from Australia, who kindly stepped in. Ryan had to leave. We welcome you to this session, which is a special session funded by American Heart Association on behalf of the journal, our journal, Hypertension. And this is a clinical pathological conference. We film the session, and there are special rules here of engagement for both the presenters and the audience. So you will see that two cases, puzzling, difficult, very, very interesting, will be presented, and there will be time for really engagement with the audience and a big discussion. And we would like colleagues who come to microphones to not only identify themselves, but also afterwards to come and give their names with correct spelling and the email to Denise. Denise is in beautiful red jacket in the front. Denise waved to everybody. And Denise will make sure that your comments are captured. And if appropriate, and if you so wish, you'll become a co-author of the paper that will be both as a film on our website and as a paper in our journal. So great opportunity, just talk a little and have a paper in hypertension. Doesn't happen every day, so you're very encouraged to participate, please. So without any further ado, our first case will be presented by Dr. Erin O'Callaghan and Dr. Patel. Both come from Bristol, United Kingdom, and they will talk about chronic deep brain stimulation decreases blood pressure and sympathetic nerve activity in a drug and device resistant hypertensive patient. Please come up here. Will you have enough space?
Yes, I think we were going to have Nick sitting where you are so that he could easily access. Great. Okay, good morning. First, we'd like to thank the hypertension editors for inviting us here to present this really fascinating case. So the structure of this talk, I'll first, because it's a bit of an unorthodox treatment for resistant hypertension, I'll first go into a bit of the background of the technology with the rationale for its use in hypertension and break for questions before going into the actual case. Also, disclosure, deep brain stimulation devices are not currently labelled for use in hypertension. So as the audience is well aware, up to 40% of patients with hypertension remain unresponsive to treatments despite the plethora of antihypertensive medications that are available. And approximately up to 14% of these patients will be resistant to medications. And this has really driven a need for new strategies to treat high blood pressure. And in response to this, we've seen quite an advancement in the range of device-based treatments for hypertension. And the most widely used at the moment, or well established at the moment, are renal nerve ablation and baroreflex activation therapy, which Dr. Jens Jordan discussed in his talk on Wednesday. Now you'll notice both of these device-based therapies aim to address autonomic imbalance in hypertension and specifically aim to decrease sympathetic nerve activity. But despite their availability, there is still a large number of patients that are not responsive to drug or device-based therapies. And this is where we're introducing deep brain stimulation for consideration. We came across this technique through Dr. Nikunj Patel, who's beside us here. He's a consultant neurosurgeon at North Bristol NHS Trust Hospital, and he routinely uses this technique in treatment of patients with neuropathic pain or Parkinson's disease. And he published a case report not too long ago which presented a patient that he'd prescribed deep brain stimulation, or DBS, for the treatment of intractable neuropathic pain. And this patient also happened to have high blood pressure, an ABPM of 158/87, despite quadruple antihypertensive therapy. When deep brain stimulation was implanted and initiated in this patient, he observed a significant decrease in systolic blood pressure that was maintained such that all antihypertensive medications could be removed, and it was maintained below 120/80 for 3 years after initiation of DBS. Now, this might not be remarkable if it weren't for the fact that the patient's pain levels returned to their pre-DBS level within only a couple of months. So this was the first observation where a change in blood pressure was dissociated from a change in pain, and that led us to consider that deep brain stimulation could be useful for central target of hypertension. So a part of the mechanism of this, the location that Dr. Patel uses in this patient for the electrical stimulation is the ventrolateral periaqueductal gray. And we know from a lot of human and animal studies that this part of the brain is a region that coordinates the defense response. And it receives neuronal inputs from higher brain centers and coordinates an output via brainstem structures. And these outputs have direct projections to control sympathetic nerves driving the vasculature. And there's also recent evidence that manipulation of this brain target can improve baroreflex sensitivity, which could be another way which we can control to provide long-term control of blood pressure. So what we have is an intuitive brain target that we can use a clinical technique of deep brain stimulation to manipulate arterial pressure in patients. So deep brain stimulation, whilst it's new to the field of cardiology, it's quite well established in the field of neurology and has been in use for over 20 years. It was first described for use in treatment of chronic pain, but is more commonly now treated for the movement disorders, especially Parkinson's disease, for which it has FDA approval and also the UK equivalent, which is the National Institute for Health and Care Excellence approval. It's also being trialled for multiple other psychiatric disorders, from epilepsy to addiction and depression. In Bristol, at North Bristol NHS Hospital, DBS has been in use since 1997, and they've implanted well over 800 patients to date successfully. It has an excellent safety record. There's less than 0.3% reporting of serious adverse events, particularly of hemorrhagic stroke, and the majority of these were asymptomatic. And part of the safety, the reason for this high level of safety at our hospital in this technique is the technology and methods that is used for implant of the electrode. So there's quite a lot of effort that goes into the pre-planning before surgery for the implant of the electrode. Once the target brain region is selected, CT angiography and MRI are used so that to plot optimal trajectory of the electrode, where you can specifically avoid blood vessel damage and avoid other brain nuclei to reach the brain target. And this also has an incredible level of accuracy, where we can reach brain targets such as the ventrolateral periaqueductal gray, which has an area of approximating 3 millimeters cubed. And this region can be targeted with less than 0.5 millimeters of error. So we have a highly precise and direct way of implanting electrodes. In the patients, to receive the electrode, we use a robot-assisted stereotax, so with laser-directed optimization of the targets. And this leads under general anesthesia, the patient can be implanted first with the guide cannula along the trajectory, and a dummy electrode can be placed in this guide cannula such that on-table CT can be used to confirm that the electrode is in the correct place. The dummy electrode can then be removed and replaced with the active electrode, which is implanted, secured, and then the lead is tunneled subcutaneously to the implantable pulse generator that can sit in the subclavicular pocket. Now, importantly, after the patient is recovered from this operation, the physician can then externally control the outputs of this device. And there are multiple contacts on the lead that sits within the brain, and the physician can activate individually the different contacts and the outputs from each contact, such that you optimize the area and volume of tissue that is activated by the stimulus. So what I've shown you here is a very precise technique for activation of a target brain region, which we've selected, the ventrolateral periaqueductal grey, as a target for controlling blood pressure. And we're happy to answer, any questions, and after questions we'll present the first time we've used this technique to treat someone with resistant drug and device resistant hypertension.
Okay, anything to add at this stage?
Just to reaffirm that this is a very well-established technique and is used in the treatment of Parkinson's disease, and since its inception over 100,000 patients have been treated, and that's an exponential rise in the sort of future. And so in terms of the technology and the invasiveness, it's well appreciated, and we've actually developed a very, very streamlined robot-based method of application under general anesthesia without any distress and under very serene circumstances. And hence the hurdles towards adopting this, providing we prove correctly that it may be effective, would be less so.
Okay, could we have questions from the floor? Could you please come to the microphone and identify yourself? That's absolutely essential because we're filming.
I just miss whether this is done once or how frequent would that be necessary, the stimulation? Or is it permanent? I was a bit late, perhaps. I missed this part of the presentation. How frequent? Is this something you do once? Or how sustained is this procedure?
In terms of implanting the procedure, or implanting the electrode, it's just done once, and it's connected to a implantable pulse generator or pacemaker, which is situated underneath the clavicle.
And how frequently do you need to do the actual stimulation, or is it a continuous stimulation?
It's a continuous stimulation at low frequency, and we'll show you some of the parameters as the talk evolves. And it's a rechargeable system, and because it's on very low frequency, the patient has to recharge the generator usually once every 3 weeks for about an hour.
Okay, so the second microphone first.
Sean Stalker, University of Pittsburgh. You just commented a little bit on my question, but I was wondering if, as the presentation moves forward, if you could comment upon how the stimulation parameters are established. You mentioned that the periaqueductal gray is about 3 millimeter cube distance, and so when you start thinking about current intensities and indirect side effects as far as affecting other brain regions, I was curious, as the presentation moves forward, if you could comment upon how those parameters were established.
Go.
Yeah, well, I'll start by alluding to where I implant the electrode. It's usually to the depth of the superior colliculus to minimize spread into the oculomotor nuclei. And in terms of the frequency, we know that low frequency has a stimulatory effect, and in terms of treating pain, or the analgesic effect is based on low frequency as well. Now, the early work done in animal models and in humans in the acute setting within the operating room was done in Oxford, and they found that stimulating at low frequency in the ventral part of the periaqueductal gray resulted in a hypertensive effect, and on the converse, stimulating the dorsal part of the periaqueductal gray resulted in an increase in blood pressure. So we had some basic science and acute studies in humans that directed us as to what we would need in these cases when we implanted it.
With most forms of chronic physiological nerve stimulation, you get some sort of adaptation. Is there any suggestion in the other applications of this technique that happens?
Yeah, as was established in this case, the gentleman actually had a good acute response to his pain. However, this did not last beyond 3 months. And that tolerance, luckily, was not extended to his blood pressure control. We also found that if we switch the system off, and often it's used in to counteract any tolerance, we were not able to re-establish the pain response, but we could reversibly alter his blood pressure. So when the system was switched off, his blood pressure would rise, and when it was switched on, we could reproducibly bring it back to a controlled level.
Okay, so we have a second microphone again, and then first.
I'm Salgado from University of São Paulo, Brazil. Maybe I have missed the information. How many patients have you implanted and did the stimulation? And did you combine the MSNA recording in order to show that there was a sympathetic inhibition?
So the patient we referred to just before, there was no muscle sympathetic nerve recording in that. That was a novel serendipitous finding. The patient that we're going to present in this second half, we have done MSNA recordings, so we'll show you that data. And to date, the patient that we're presenting in the second half, that is the first patient in the world to receive DBS solely for hypertension.
Thank you.
It'd be good to get on to the case, so we'll have one more question, if that's...
Maybe that just answered my question, but what are the plans for a randomized trial or control
Obviously,
study?
based on the evidence you've already seen, it's on the way.
Okay.
We will present that and show our
With
suggestions at the end.
Ambulatory blood pressure.
Yeah.
Yes, the whole shebang.
Let's see how convincing the case
case,
is,
yeah.
and then
Yeah.
we'll discuss that.
Fairly confident you'll be convinced that her blood pressure is exceptionally high and resistant. Okay, so as promised, let's move on to our really interesting case. So this lady, she first developed hypertension at the age of 37, and this followed 4 successful pregnancies without evidence of preeclampsia. She's a German lady. She's 51 years old when she first presented to us and postmenopausal. She's not obese, and quite the opposite. She's incredibly slim and her BMI is 18. She is not smoker, not diabetic, and she does have focal epilepsy, and this was diagnosed after her development of hypertension. And there is some familial history of hypertension. Both parents are hypertensive, and her father had an MI at 70 years old. Both are still alive. So as I said, she was first diagnosed at the age of 37 by a German GP, and her pressure at that time was 160/90. It progressively increased despite drug treatment according to the current guidelines, and she was classified as resistant hypertensive by the age of 41. And by the age of 43, despite the drug interventions, her blood pressure had reached more than 220/120. And this acceleration in her increase in blood pressure is quite fast and is a bit atypical of essential hypertension as we understand it. So she was sent to a hypertension clinic, was referred to a hypertension clinic for investigation for secondary causes. However, they found no secondary causes, which I'll go over in the next slide, and her blood pressure, not only was it not lowered by further treatment, but it continued to rise and reached 280/130 millimeters of mercury by the age of 46, which led to her further referral to a specialist hypertension clinic in Hanover, which is a centre for tertiary referrals for hypertension, where she underwent further investigation and treatment. So she was quite comprehensively screened for secondary causes, and these were published not that long ago in a case report in Hypertension by Schroeder et al. And they described the techniques that they used for excluding the secondary causes listed here. They also confirmed that she was compliant with her drug regime by drug metabolite analysis, as well as observed oral ingestion of her medication. And her drug medication managed to reduce her blood pressure. This was measured by intra-arterial line, from 280 to 250 millimeters of mercury. So it wasn't addressing her severe hypertension. So as I said, during her visits to the hypertension clinics in Germany, they optimized and titrated her medication list, but by the age of 46, she was taking 8 antihypertensive medications daily, and I'll go over those, what they were in a little bit. As this obviously wasn't controlling her blood pressure, she was referred to the hypertension clinic in Hanover, and they investigated her for autonomic dysregulation and potential eligibility for what was a new clinical trial at the time, which is baroreflex activation therapy. So she was enrolled in this trial and received the first generation Rios CVRX Barostim, and initially it was successful in treating her blood pressure and reduced her systolic pressure by 60 to 80 millimetres of mercury. However, after 3 months it continued to rise again and exceeded reached its previous levels. So 2 years later she was enrolled to receive renal nerve ablation, and she underwent Simplicity catheter, Ardian Simplicity catheter, renal nerve denervation by a highly experienced clinician in this technique. However, this had absolutely no effect on her blood pressure. And at this stage, she was quite desperate for new treatments, and she actually discovered Dr. Patel's previous case report from her own internet searches and contacted him directly, nearly begging for enrolment in a trial to receive deep brain stimulation. So we couldn't resist having her arrive, a patient this exceptional. So we invited her to Bristol to undergo screening, and she was screened by cardiologist Dr. Angus Nightingale in his hypertension clinic at University Hospital Bristol. And we attempted to use a standard automated blood pressure cuff on either arm. We were unable to get a reading from this lady because the cuff could not reach the limits. Her blood pressure exceeded the limits that were detected by a cuff. And for anyone that's not aware, the cuff limits are 299 millimetres of mercury. So we confirmed with a manual aneroid sphygmomanometer. We went old school, and this showed the dial was fluctuating wildly between 300 and 350 millimetres of systolic. So that confirmed that her pressures were absurdly high. We connected her to finger plethysmography fingerpress for about an hour while she was lying down on a bed, relaxed, and her pressures were maintained above 300 millimetres of mercury for this period. We were curious how much this high blood pressure was a white coat effect, so we attempted a 24-hour ABPM, probably optimistic. And not surprisingly, we only had one successful reading at 235 over 140, the rest of the readings being unsuccessful due to her pressure being too high to be detected by the ABPM. And these high pressures confirmed or corroborate her previous home. She keeps quite a strong record of her home blood pressures and visits her GP fairly regularly. And she was reporting that when she could measure her blood pressure, it was in the region of 200 to 280 to 290, and her GP confirmed this. And this was in the 2 years prior to seeing us, and in the 1 year prior to seeing us, more often than not, she was unable to record her blood pressure. And just to remind you that these pressures are extremely high in the face of baroreflex activation therapy, renal nerve ablation, and 8 antihypertensive medications. And these medications are listed here, and you'll notice that there are 8 different drugs, and these drugs cover 7 different classes used for antihypertensive treatment, the doses of which add up to a whole drug equivalent of nearly 13. And for those that aren't aware, most resistant hypertensive patients will be on the equivalent or less than 4 whole drug equivalents. So she's received quite an army of medications to try and control her blood pressure, which have been unsuccessful. And this is obviously quite a list of medications to be taking daily, which is not ideal. So to her symptoms, she does suffer from symptoms of her high blood pressure. She gets severe headaches 1 to 3 times a month, and these are debilitating headaches that leave her bedridden. She feels generally unwell and severely lethargic. She was unable to work due to a feeling of lethargy, and was often in bed by 5 o'clock because she was too exhausted to continue. In terms of her other signs, she has only mild concentric left ventricular hypertrophy and mild hypertensive retinopathy. She doesn't have any evidence of other end organ damage. There's no microalbuminuria, she hasn't had a stroke or ischemic heart disease or infarct. So she's quite impressive in that she is maintaining these extremely high blood pressures without enormous side effects and end organ damage. So before we considered implanting her with a deep brain stimulation device, we wanted to make sure that our hypothesized method of action would be useful for her. And as we expect that deep brain stimulation is reducing sympathetic nerve activity, we wanted to make sure that she actually had high sympathetic nerve activity to begin with, given that she had had all these therapies that are supposed to be reducing it. So Dr. Hart used micronography to measure her muscle sympathetic nerve activity, and she found that she had, at rest, 56 bursts per 100 heartbeats. And when normalised for body weight, because she had quite a low body weight, this did show that she was much higher than women at a comparable age that are normotensive. So we thought this justified use of deep brain stimulation to try and help her lower her blood pressure. So this is now showing you the results and data from DBS. This is before receiving deep brain stimulation, and these recordings are arterial pressure and heart rate from her home blood pressure diary, which she keeps rigorously. And these are on 8 antihypertensive medications daily and with baroreflex activation therapy. So you can see that she was averaging between 260 and 300 millimeters of mercury systolic for the 2 years prior to DBS. So we implanted DBS and switched it on, and in the 3 months following initiation of DBS, her blood pressure had decreased dramatically. And she was feeling a little tired just feeling a bit tired, so her antihypertensive medications were withdrawn to prevent her blood pressure from dropping lower, because despite them still being above what a recommended target was, this was obviously having side effects for her. So in the year follow-up afterwards, her blood pressure did rise a little bit in the year following DBS. However, her heart rate was also rising, which meant that she was reinstated with a beta blocker, metoprolol, and this was the only medication that was reinstated, and she refused any further addition of drug therapy. So we don't know if this pressure could still be brought down further again by adding more drugs to her daily list. And we've followed her out for 2 years now, and her blood pressure has stabilised at this new lower baseline, about 220 over 140 millimeters of mercury. And whilst this is still considered quite high, the patient reports to be feeling much better. She doesn't have as many, her headaches occur less frequency and are less severe. She's back to work, and she works on a farm, and she's also back to horse riding, so she's enjoying her quality of life a lot more at this new lower pressure. So she kindly allowed us to continue investigating her from a mechanistic perspective and allowed us to measure her muscle sympathetic nerve activity after DBS was initiated. And on the left here, if you can't see clearly the scale, this is a Finepress blood pressure, 270 to 140 scale before DBS, and you see a larger number of bursts, MSNA bursts occurring, compared to 3 months after deep brain stimulation. There are fewer bursts. And this new scale is 230 over 130, I think. So her blood pressure is lower and her MSNA is lower 3 months after DBS. We again recorded her MSNA a year afterwards, and this is the graph I showed earlier with her before DBS levels of normalised MSNA. And she's now sitting comfortably within the normal range of MSNA, but normal is a strange word to use given how high her blood pressure is. It should have no MSNA whatsoever. So based on this, we think we have treated her blood pressure by reducing sympathetic activity using this technique. So to summarise before questions, what we've shown here is the very first use of DBS to treat solely for the use of treating hypertension. And we've shown that it was safe in this patient and effective at decreasing her blood pressure. And we think this does justify systematic testing of this technique in patients with very high blood pressure that are resistant to current drug and device therapies. In terms of this patient, in particular in her future, we'd very like to hear what your thoughts are. Given that her blood pressure is still over 220 over 130 and she doesn't have that much end organ damage given these longevity of her high pressures, we are wondering if perhaps she needs high pressure to perfuse these target organs, and we're considering if perhaps she has some vessel tortuosity that's that's driving up her pressure to be able to perfuse the organs adequately. But as I said, we'd very much like to hear your input. And before we break for questions, I'd like to acknowledge the team of people that have helped with this patient, with Dr. Patel, his team at North Bristol NHS Trust Hospital, the team at University Hospitals Bristol and Crick Human Research Lab, as well as at the University of Bristol, Dr. Payton, and our collaborators at Hanover Medical School here. So thank you, and we look forward to your questions.
I think this is really an extraordinary case. I suspect that in the audience, not many people have ever seen blood pressures of this number. Could we ask the audience by raising the hands up, have you ever seen systolic blood pressures and diastolic of that level sustained over a period of time? I calculated that this is 14 years and so little end organ damage. It's incredible. Can we have a show of hands? Anybody ever seen pressures like that? Yeah. Right, I haven't. Yeah. So very few. So I hope...
Does it count if it's the same person?
It doesn't. Sorry, at the back there doesn't count. The same patient doesn't count.
The true test is when the mercury flows out the top of the sphygmomanoid.
So I am not persuaded by the argument that she needs this pressure to perfuse her organs. In that case, we would have seen many patients of that type, and we do not. There is something really unusual. So I think Professor Luft is going to say this, but can I, before he comes, can I ask, you haven't shown us any pictures, detailed brain architecture, MRIs, etc. They must have been done. Was there anything abnormal in this brain to drive this blood pressure?
I mean, she had a MRI scan before she came to us, and it looked entirely normal, with also very little small vessel disease change. And subsequently, I used that pre-existing MRI because I could not do another MRI scan in view of her implanted Rios system. Yeah. And I used a CT scan which aligned perfectly with that MRI. So there was no change in cytoarchitecture or small vessel disease phenomena or anything to suggest multiple end organ TIA related changes.
Okay, we've got a question.
Lars Lindholm, Sweden. I'm fascinated, of course, by your story here and about the patient. Could you tell us a little more about this lady? Apparently she is a skinny lady with 4 kids going about life just as any ordinary. Is there anything else in the, I mean, you must know a lot about her. I mean, how can she cope with this blood pressure?
That is exactly what we'd like to know as well.
I mean, isn't there anything, it's just headaches, of course, but intermittent headaches, but nothing else?
I mean, she had a history of presumed epilepsy, and we were wondering whether these were syncopal phenomena, but without a TIA related event. But she was incapacitated regularly, and every month she would have periods where she could not function, and usually because of these intractable headaches. She was on medication for angina as well, but didn't suffer significant bouts of, chest pain. But we were equally bemused. And my first response when I saw her email was probably to run in the opposite direction.
Well, I suppose you need to invite her to one of our big meetings. We can all meet her and see her.
She's a remarkable lady, and would be very pleased.
Right. So I think we have first microphone and then Fred Luft.
So George Rausch from UConn. What is the correlation between the level of sympathetic nerve activity and the expected blood pressure? Is it higher than, are there data correlating these two variables?
Well, it's difficult in premenopausal women, it's not so correlated, but in postmenopausal women, such as our patient, and in men, there is a correlation between higher sympathetic activity and higher blood pressures. But we don't have a huge understanding yet of the causative role in the... well, I think actually the other day there was quite a good figure showing that the progression of higher sympathetic nerve activity in patients that are normotensive, borderline hypertensive and resistant hypertensive, and it does increase with the increasing pressures in those patients.
Yeah, sure, but I assume that the blood pressure is much higher than one would have expected for that level of nerve activity.
Yes, it is, absolutely.
But just on that, we do see people with other disorders who are normotensive, such as panic disorder, some people with heart failure who've got these kind of burst frequencies. So it's not a direct relationship.
Okay, Fred Luft.
Fred Luft from Berlin. This lady was under our care when she was in the Berlin area for several years, and then when Jens Jordan and Christoph Schröder moved to Hanover, they took over her care there. There are several remarkable things. At these kinds of pressures, her sympathetic nerve activity ought to be zero, and it's not zero at all. She had MR angiography, as I recall, looking at this putative neurovascular contact syndrome at the rostral ventral medulla, and that did not appear to be the case. She reminds me of the genetic hypertension that we're studying that's caused by mutations in phosphodiesterase 3A, because these people also have normal sympathetic nerve activity at profound blood pressures, and they also have no target organ damage. They die of stroke, presumably cerebral hemorrhage, although we don't know that for certain because we didn't have an opportunity to study that, since they respond to medications, but it takes 3 classes, but they do respond to medications. One comment and a question. I think it might be worth, and I'm sure she would allow this, we never gathered cells from her. If she would undergo a fat biopsy, we could culture mesenchymal stem cells and convert these to vascular smooth muscle cells and look to see if the pathways are somewhat similar to what we found in this genetic form of hypertension. My question is, would bilateral stimulation be perhaps more effective? Because it looks like you're about halfway there.
Right.
It's a good question. I mean, we do know that with unilateral stimulation of the periaqueductal gray, you will get bilateral effects, and the stimulation will spread across the midline. I think the risks of putting 2 electrodes maybe outweigh trying to capture more changes in blood pressure. I still feel we have maneuver and room for reprogramming to try and enhance the effect that she has sustained to date. And throughout, she's been fairly adamant that she does not want any further antihypertensive therapy reintroduced, and felt that the side effects from this were intolerable.
Okay, I think we have the last question at the microphone. Yes, yourself?
Irv Zucker from the University of Nebraska. One way you can get increases in sympathetic nerve activity in the face of high blood pressures is by enhanced input from excitatory inputs from the periphery. We have a study that we're showing this afternoon in SHR rats showing that ablation of dorsal root ganglia afferents in the thoracic region can reduce blood pressure. Now, you mentioned that she suffered from angina. I wonder if there were any other pain syndromes that could be driving the increase in blood pressure, even if there's not a conscious awareness of pain. And the second comment is whether or not the deep brain stimulation is activating vagal pathways, such as would occur for vagal stimulation for depression or Parkinsonism. Do you have any insight? Because since you did microneurography, you probably did things like cold pressor tests and Valsalva maneuvers to evaluate those 2 arms of the regulatory pathways for sympathoexcitation.
We didn't do those regulatory tests. We didn't feel comfortable with it given her high pressures, but
right.
They were conducted previously by Jens Jordan and his team, I believe. And she was found to have normal baroreflex control, impressively.
Really?
Yeah. What was I going to say? Oh, we do know also with regards to this deep brain stimulation and vagal control, we do know from a lot of animal work that there are direct projections from the ventrolateral periaqueductal grey to cardiac preganglionic neurons. So we assumed that there could be potentially some effect there, but we haven't analysed it specifically in this patient.
Would Dr. Jordan like to comment? You're very welcome. No? No comments. Okay. Right. Are there any other final comments from the floor? I think this is an incredible case, and we're really, really keen to publish it with all your comments, because I think that will be something that will stay in the literature and will be referred to for years to come as a case of extreme hypertension. It's more than resistant, it's sort of super resistant hypertension. So any last comments from the presenters? No? You happy with the way we discussed?
I've just got one last question for the audience. How many of you are ready for a randomised controlled trial? And,
Good
perhaps
question.
put your hand up if you think, and how many would like a bit more information before?
Nobody wants to do. Oh yes, there is one. There is one. Two.
Yay.
Yeah. Okay.
Okay. We're not very brave, clearly.
No,
not very brave.
I'm not sure we can leave it at this, but let's move on to the next case anyway.
Okay, so
Thank
thank
you
you
very
very much, presenters. Thank you.